the ending AIDS in children by 2030. So I'll just be looking at the elimination of mother-to-child transmission, that is EMTCT, and I'll also talk about the pediatric care and treatment, just to give us a general picture of where we are at, where we have come from, what the status is. So I have an outline, a brief one. Oh, thank you. Yes. So I'll do a short introduction, then we look at CAL HIV. So CAL HIV is children and adolescents living with HIV. We just look at where we are at currently in terms of our status, our data, and how our children are doing. Then we look at the sources of infection or new infections for the children. And then we look at elimination of mother-to-child transmission. What does it entail? What is it? What do we do? And also look at a little bit of some performances or our performance as a country, and also the counties in terms of the mother-to-child transmission rates. Then we'll also look at the progress in ending AIDS in children in Kenya. Now, where are we? What have we been doing? What strategies do we have in place? And what have we set in place to move forward? Okay. Oh, sorry, technology. Not moving. Okay. So this is just a brief on the statistics according to the estimates of 2023. So overall, we have an HIV prevalence of 4%, with a prevalence of 5.3 in the females and 2.6 in the female and in the male, sorry, and a total number of 1.377 million people of all ages living with HIV. When we look at the adults, we have 1,309 309,915 approximately of those that are over 15 years. And then for the children of 0 to 14, we have approximately 67,869. And then those that are getting new infections or have gotten new infections in this year, all ages, 22,154. Amongst them, 17,860 are adults, and we have 4,474 children. And then for young adolescents and young people, we have 88,853 living with HIV, and those that got new infections, 3,244. And then for those that are between the ages of 15 and to 24, those are the young adults, we have a total of 145,142. And new infections amongst this population group is 7,307. Sorry. So Kenya has made very significant progress in terms of controlling the HIV epidemic. And when we look at the UNAIDS standards, where we talk about the 95, 95, 95 cascade, we are seeing that the adults are doing very well, or the general population is doing very well. I don't know if this is the pointer. Okay, yeah, but so we can see that when we look at all population for the 95, 95, 95 cascade, where the first 95 is 95 of all people living with HIV being diagnosed or being identified, and then 95 of all of that category being on treatment, and 95 of those that are on treatment being virally suppressed. So for the general population, you can see the performance there. 94, is it 94, 95, my side from here, then 94 and 89. Then when you look at the adult population, we have 95, 95, 90. But when you look at the children, we are at 85, identifying them. And then 85 of those that have been identified are the ones that are on treatment or ART. And out of the ones that are on treatment, only 74% are virally suppressed. So you can see that the gaps are quite glaring with this data that we have, and clearly the children are being left behind. And this calls on us to do something concerning the children. So if we go deeper into the cascade, we see that this is how the numbers look like, or what the 85% represents. So the line you can see, and those that are currently on ART are also 85. Virally suppressed are 74, just to give more clarity from the 95 cascade that I've shared before. Okay. Yes, so this diagram just represents the number of or percentages of children that are being covered or on treatment, especially 0 to 14 years. And then we are comparing to the adult population, that is the 15, going onwards. And we are seeing the trend from the year 2010 all the way to 2022. And we can see how the blue line that represents the adults has been steadily, going up in terms of coverage. And then for the children, we had a steep increase at some point, and then we are on some form of plateau right from the year of 2017. So it means even for treatment coverage, we are not doing very well for the children. And for optimization of care, we now have the DTG regimen that is the recommended regimen for all children. So when we moved the children to the DTG regimen, we are seeing here that we still have a gap, or we still have a number of children that we have not been able to reach for us to be able to optimize. So that means even those that are on care, not all of them have been optimized. We are at 86% performance currently. And then this is the coverage in the country in terms of our counties. So you can see the areas where we are having lower coverage of DTG of less than 20%, the northeastern side mostly. And then as we move towards the right side of the map, it's getting brighter, meaning that the percentages are increasing. And then where we have even lighter colors, we are seeing Siaya, Homa Bay, around that area where we have more than 90% DTG coverage. So we can see that the treatment is affecting children. So we have 6 children dying every day due to HIV AIDS-related reasons. And the causes of death, actually, when we look at them, these are preventable. Pneumonia is a vaccine-preventable disease. Malaria is also preventable. We have several means of preventing it. Malnutrition is also preventable, and sepsis, also calling them infections, are also preventable. So we see that maybe one of the reasons to us why we are getting this or we are seeing this data is because once a child has acquired HIV, if we don't give them the proper care and treatment that they require, then the statistics are actually shocking that 30% or a third of these children actually live to age 1. And 50%, if they don't get any care and treatment, get to age 2, and only 80% get to age 5. So you can see how our children are really being affected. And apart from mortality, we also have those that are HIV positive and are not getting the proper care and treatment regressing in terms of their progression in milestones. So now let's look at the new infections in children. I think at this point it's also important to remind ourselves, for those of us who already know and those of us who are new, what are the modes and risk factors for transmission from mother to child? So we have 3 areas that a child can be infected vertically. So we have during pregnancy. We see especially if the risk factors are high viral load in the mother, intrauterine infections, malnutrition, and anemia. A child can also be, or an infant can, fetus can be infected during labor and delivery. And risk factors include high viral load, placenta separation, rupture of membranes of more than 4 hours, invasive procedures, vacuum extractions, and chorioamnitis. And the other way that an infant can be infected is that during breastfeeding, especially if the mother has got a high viral load, there is mixed feeding that is happening. The mom has got breast abscesses, nipple fissures, oral lesions, and in the baby, so that now there's a way that the virus can get through. Again, when we categorize the new infections that are happening, if we look at the adolescents and the young people, just to give us more data on where the new infections are actually happening, you can see the different age groups. Between 0 and 9, we have 15%. Between 10 to 24 years, we have 35% of this age group getting new infections. And then 25 to 34 years, we have 29%, 35 to 44, 14, and over 45 years, 7%. And then when we categorize them further into male and females, we can see that we have more females being infected in this age group. So, and these females are actually females of that are within the reproductive age. So we have a higher risk of this group actually getting new infections, and if they don't get the proper care and treatment, then transmitting to their infants. This gives us more details on when exactly or how or the infections or the new infections happen. So we are seeing the highest number being mothers who did not receive antiretroviral therapy during pregnancy or breastfeeding. So if a mother is HIV positive and they don't receive their ART, from the data that we had from 2020, 1,558 of these were transmitted to their infants. And then mothers who stopped antiretroviral treatment during pregnancy or breastfeeding, 1,431. And then mothers that acquired the HIV during pregnancy, so they were diagnosed newly during pregnancy. And then we also have mothers on antiretroviral treatment but did not achieve viral suppression. So if a mother does not achieve viral suppression, then transmission occurs. This just to give us more insight on the different percentages of how the transmissions or where the transmissions are occurring. And a summary is that 67%, the absolute number is given there, of new HIV infections in children, that is 0 to 14, were attributed to either pregnant and breastfeeding women not receiving ART, that's 35%, or having their treatment interrupted, that's 32%. So from this, we are seeing that it is very important that an HIV positive mom gets treatment and they continue to be on treatment. Adherence and retention as one of the main pillars of prevention of mother-to-child transmission. This one here also shows us new infections as well. So we see 12 children being get infected every day in the nation, and we have a trend that the map is giving us a trend from the year 2010 to 2012, and we can see the relationship between pregnant women ART coverage and the number of new HIV infections in children. So just generally, the higher the coverage amongst pregnant women, the lower the new infections occurring. So we can see the relationship between ART coverage amongst pregnant women and also the new infections. So now we're going to look at elimination of mother to child. So we've already seen from our discussion so far that it is very important for us to have timely initiation and support for HIV treatment for pregnant and breastfeeding women that are living with HIV for us to reduce mother-to-child transmission. And this is the cornerstone really of having children that are going to be HIV-free. But also timely testing and treatment of children who are HIV infected is very critical to avoid or to prevent them from deteriorating into AIDS and dying. So for prevention of mother-to-child transmission, when we are not just talking about HIV, we are now speaking of triple elimination, where we are eliminating HIV, syphilis, and hepatitis B. So it means that we need to offer comprehensive care in antenatal care for us to be able to achieve mother-to-child or to prevent mother-to-child transmission. So it means then we are saying that all women, unless they are already non-HIV positive, should receive counseling and testing of HIV, syphilis, and hepatitis B during their first ANC. But also it is important for us to repeat the test, and we are using dual tests to be performed in the third trimester if we found them to be negative in the first test. So we have 4 prongs in PMTCT. So this is what are the 4 main things that entail prevention of mother to child. So the first one is primary prevention. So we were saying those that are HIV negative should remain HIV negative. So we are preventing them from getting new infections among the women of childbearing age. That is prong 1. Prong 2 focuses on preventing unintended pregnancies among women living with HIV. So here we focus mainly on contraception and family planning. And prong 3, we are preventing private facilities that they attending clinics where because we don't have that data in our routine data. And then those that have got known HIV status, we are at 84%. Those that were screened for syphilis, 85%. And those that completed the 4 visits, 58%. And those that had skilled deliveries are 84%. So we say there's transmission even during labor and delivery. So if we are not having skilled deliveries, we are also at risk of transmission to infants. So ending AIDS in children, what does it mean? 2 things, and those are the main goals. The first one is we need to close the tap, and this is elimination of mother-to-child transmission. So we need to eliminate all missed opportunities. As we've seen, the data that I've been presenting, we have quite a number of missed opportunities. So we need to close the tap. And then we also need to follow up both the maternal infant pairs. We've seen that we have discrepancies where the mother is getting care and treatment, but the baby is not. So it means that in our cascade of care, we are losing out on the babies or losing out on the mother. So we need to longitudinally follow the pair as it is children. So the government is very much committed and has made a commitment towards this. Our CS Health made a commitment on the 1st of February in Dar es Salaam to fast track ending AIDS in children together with the other 11 counties. And as to this, our president has reiterated that commitment, and he has actually said we don't need to wait for 2030 for us to end AIDS in children in Kenya. We need to do this faster, and we can actually do this faster because we are able to identify where the gaps are. Once we address them, then we are on the right track. And so he has given us a deadline or a timeline of 2027. He's actually brought the goal closer. So there's a Kenya plan to end AIDS in children by 2027 that now we have dubbed Wakati ni Sasa, End AIDS in Children, and we are redirecting all attention towards the vulnerable groups because we have had groups that have been missed out before, and we now want to target those specific groups. And these include the children, as we have said, we've been lagging behind, the adolescents, as we have seen, most of the new infections are coming from this age group, and then we also have the pregnant and breastfeeding women. And actually the plan is leveraging on the 4 global alliance pillars, which include early testing and optimization, early testing and optimized comprehensive high-quality treatment care for infants, children, and adolescents that are living with HIV, and then also closing the treatment gap. As we have seen, we have got a big gap in the pregnant and breastfeeding women that are living with HIV, and then optimizing them continually, or optimizing their continuity of treatment towards the goal of elimination, because we have said starting them on ART is not enough. They need to adhere and they need to be retained in care for us to achieve this goal of ending AIDS in children. But also we are focusing on preventing new infections among pregnant and breastfeeding adolescents and women, and again going ahead to address rights, gender equality, social structural barriers that hinder access. So we are deliberately saying we are not leaving anybody behind. And that is one of the calls that we have, even as we are moving on with the agenda of Wakati ni Sasa, End AIDS in Children. So who has been left behind? The adolescents, the young people, the people that are living in rural areas, informal settlements, arid and semi-arid areas, men, private sector, and religious communities. So right now we are incorporating or bringing on board all these groups that have previously not been in the PMTCT space. And we have an RRI, that is a Rapid Results Initiative, that we have started implementing. And really we are using this as a platform to just kickstart this journey of ending AIDS in children by 2030. And for us, it's actually 2027. So the first agenda for the RRI is to just look at the missed opportunities that we had. So we reviewed data between May last year and between March last year and May of this year to just look at what are the missed opportunities that we have in the different areas. One, in HIV testing of mothers that come to ANC. Number 2, after they have been tested, how many of them missed to be put on ART? And also how many children missed to get their infant prophylaxis? How many children have we missed to do an EID, that is the early infant diagnosis for? How many children are still virally unsuppressed and mothers that are virally unsuppressed so that we can be able to reach them? And as I presented before, we still have children that have not been optimized in care, which is also a missed opportunity. So it's a matter of just looking at all the missed opportunities, and we are targeting to address at least or mop up at least 95% of this missed opportunities. And then we are saying we are using but we are calling on on everyone's support. So we are bringing on board all the stakeholders, right from the top leadership to the very grassroots level of the community, just to hold our hands together so that we are able to move this agenda forward. And we are saying we are bringing on board non-traditional key stakeholders. For example, we've been leaving out the child protection officers. When you find a 12-year-old, 13-year-old pregnant, it means that defilement took place. But as clinicians, mine is to take care of that. We call them a mother, but they're actually a child. So I give whatever care clinical that they need, and I allow them to go without, thinking of where am I releasing this child to go to. Maybe I'm releasing her back to the perpetrator, and things like that. So we need to bring the child protection officers on board. The private facilities, as I said, from our data, we are seeing that we have a 10% of data that we cannot account for. Are these women or these children in the private facility? So we need to bring on board the private facilities as well. Our associations, the Kenya Pediatric Association, and we are very blessed to have Prof here. She's going to give us her talk, and we can see they see children, but not all of them actually give that data. The obstetricians and gynecologists, so many women, and some of us might be here, me myself being one of them. That's where we go for our NC care. Do they ask us about our HIV status? Some of them don't. If we are HIV positive, where do they document that? Do they give us, do they link us to get ART? Or they just come and, they do the ultrasound and you keep going and you keep coming back? I think we are identifying with that. So these are very key stakeholders that we have not been, have not been involved in the PMTCT space, that now we are bringing on board deliberately, and we are looking out to them and giving them this information and telling them, hey, look, we really need you on board if we are to achieve anything in terms of ending AIDS in children. And then again, being innovative and doing things differently. If you do the same thing over and over and you're getting the same, you wouldn't expect to get a same result. So for this RRI, which is maybe we are using it really as a jump starter, we are being innovative and we are trying to think outside the box. And these are some of the interventions that we have, and we are asking ourselves, we have interventions that we've been doing before, but what is new, or what do we want to do differently? So in terms of capacity building of healthcare workers, we will have cascaded mentorship that will take the form of roving, virtual, and site level, but we also want to deliberately look at, to review files of the missed opportunities, those that are virally unsuppressed, both the mothers and the children. And then we are doing training for targeted healthcare workers, including the staff that are in MCH, because one of the things that we came to notice is an infant comes to the facility for immunization and they get fully immunized, but most of the times the healthcare worker seated in that clinic does not go ahead to see what is the HIV status of the mother, so that this baby can then be put on prophylaxis and also followed up in terms of their diagnostic tests. We're also going to start running webinars as from the week of 11th of September, and these webinars will cover several thematic areas, and we are targeting both community topics, but also healthcare worker targeted topics. And then we've developed job aids that are new and innovative, and this include client risk categorization, where we are going to be categorizing the women that are coming for NC and the PMTCT mothers, and then follow them up according to their risk. Because as it is now, we manage all of them as we say wholesale. We don't check, does this woman have a risk factor of GBV, for example? Are they a young person and they would have those things that would be associated with that risk? Do they have mental health issues, for example? We just come and see them and go. But now we have developed a tool that we are going to categorize them and then now follow up based on the risks that we will have identified, either as high-risk mothers, or if they're not high-risk mothers, then they continue with their clinics just as usual. We have referral protocols, feedback forms for case reviews, but also we have a tool that we are calling the Kanban walkthrough that we are using for the case file reviews for us to actually track each and everything that we'll be doing. In terms of supply chain, and I know commodities have been a big challenge to us, we have front-loaded the sites that we have identified using a criteria that we had, so that the facilities have commodities during the RRI, but also going forward. And we've also encouraged that at sub-county and county levels, we have monthly commodity security meetings, and then we have a circular on the last mile commodity security optimization, but also shifting from lab to facility level early infant diagnosis and viral load collection of commodities. At data reconstruction and management, and if we don't monitor and evaluate, then we have no way of telling our story or giving our successes. So we have set up a way of doing longitudinal tracking for the PMTCT clients at all sites, and also optimize and scale up the PMTCT module in the EMR, and also use the Ushauri platform for the non-EMR sites and disabled sites, but also integrate the RRI tools into the KHIS. So KHIS is our routine data collection tool, so we are integrating the tools there. When it comes to optimization of viral load and early infant diagnosis, we are re-networking, especially for the facilities that we have identified to be involved in this RRI. And also we are optimizing the testing in the labs, and as well as giving online result access, because one of the reasons that we had were long turnaround times because they are waiting for hard copies to be sent to the facilities. But this is being worked on so that we are able to give online results. In terms of structural intervention for clients, we have formal linkages with structural intervention partners with specific facilities, and also we have developed a tool for referral and resolution. Advocacy, education, and demand creation, we have cascaded advocacy and demand creation, and this is work in progress. We have developed IEC materials, and we have a platform that we are calling Ask the Expert platform, and this will also be activated in the next few weeks, where anyone, whether a community member, a public member, or a healthcare worker, can just log in and just ask a question from an expert and get real-time answers that are related to PMTCT and CAL HIV care and treatment. And also we have linkages with community strategy and CBOs as one of the ways of that are innovative in terms of advocacy, education, and demand creation. So we are calling upon all of us. We have seen all the data. We have seen how vulnerable our children are. We have seen the statistics that we have. 30% of a child that has got HIV and does not receive the appropriate care and treatment gets to the age of 1. 50% of them get to the age of 2, and only 80% of them get to the age of 5. Timely initiation and support for HIV treatment of pregnant and breastfeeding women living with HIV reduces the chances of transmission to the infant, and these are really the cornerstone of giving our children an HIV-free start. And also we have seen that for our children, they need timely testing and treatment for them not to deteriorate into AIDS and getting a mortality from the same. So we are saying the time to act is now, to end mother-to-child transmission of HIV, and also to fast-track identification and treatment of children living with HIV in Kenya. And I'm saying it again, wakati ni sasa, let's all end AIDS in children. Thank you very much.
Thank you, Daktari. We need to clap for Daktari. She has given us a lot of information in terms of the progress of the program at the national, and I think it's for us now to interrogate and reflect in terms of where we are, what we didn't need to do, and what would be contributions in terms of individuals to the areas that we are working in, and also looking at what is new for all of us to ensure that what she has presented, we can really be able to identify and define our protection. Thank you, Dr. because you have been able to give us areas of focus in terms of what we didn't need to do. And what I want to say is that, as you have said, is that there is government commitment in terms of resources, and in terms of political goodwill in all aspects. Also issues around how do we ensure that this agenda is a priority for all of us, and also work within timelines. You have talked about timely, And we need to really consolidate that in terms of the call to action that we really need to work on. For us to really get also the perspective of some of our key members of the panel, I would like to really say that we have another session on of panelists that would like to discuss issues around research, program level and community experience towards accelerating the targets and key action point that Dr. Neri has been able to analyze. And with us, I would like to, really because of time, call upon some of our key panelists who are supposed to give us an overview. I would like to welcome Professor Ruthi Dwati, who will be able to give us a perspective around linking the science to elimination of mother to child in terms of programming. Karibu sana, Professor. Also, I have a member from the community land monitoring for adherence. I would like to invite Maureen Murenga, who is one of our key friend in PMTCT. I think we started working with Maureen and Patricio Cero back in early 2000 in terms of looking at how we can then be able to spearhead this agenda. And I would like Maureen to take it in terms of giving us the community-led motivation for adherence. We have Reverend Kaida, who will also give us men as the missing link. As you have heard from Dr. Ali, there is so much that we didn't need to think outside the box. So we'd like to have a feel of a reverend in terms of how we're going to ensure that we strengthen male involvement in all this as part of our the continuity of care and also initiation of what she has talked about. I have Sipora Achien, who will be able to give us leaving no one behind, and especially more focusing on adolescents and the young mothers, which is also a very critical component for all of us, especially now we are working on issues around how do we approach the adolescents and young mothers. Then finally, we have Sama Sitima, who will give us the role of private sector. Dr. has talked about the missed opportunities, and she's worried about the missed opportunity in terms of the rates. Are these people going to the private sector or not? So we'd like to really understand what is the role of private sector in all that. So my panelists, please come forward so that we can start. So we have Professor Ruthi Dwati, we have Maureen Murenga, we have Reverend Henry Kaida, we have Sipora Acheng, and we have Sama Sitima. Karibu. Huh? Yes. Sorry, I understand Sama is online, so we will engage. Let's give Professor 1 or 2 minutes to set up. She'll. Yes. Okay. Or the Dr. Neri? Or you wanted, maybe we can give you opportunity because as Professor is setting up. Yes.
My name is Wambui, and as I was listening, he's talking about the private sector, and I got some interest, and I'm asking. Okay, sorry, my name again is Wambui Salome. I'm from Kiambu County. As Dr. Nelly was presenting, I got some interest in the private sector and how maybe we are losing the ANC and the data from that end. And my suggestion could we maybe borrow from what the TB guys are doing, because I believe the TB sector has been able even to capture data from the private sectors. And maybe from that aspect of private sector, is missionary hospital categorized in the private sector? And what is this that has made us not utilize the tools that are already existing to capture the data? Thank you.
Thank you very much. I think because we have a Q&A session, I would propose, with the permission of the panelists and the Daktari, that we can be able to note that Daktari, and maybe when it comes to Q&A, we can be able to respond, because I know many of our colleagues will also be able to align that to the presentations of the panelists. Yes, and especially the component of where we have the role of private sector in this discussion. So I think we'll start with the professor. For some of you doesn't know, professor, I think, is one of our key persons that we started the PMTCT with her in this country. Professor is one of our mentor and one of the person who mentored me in PMTCT. That was back 2000. And we were able to launch this program on 2nd of August, the year 2002. So we have been working together with the professor in this PMTCT journey, and we are able to ensure that some of the key contribution of professor cannot be ignored. So professor, I will give you this opportunity to really give us a shot on how we are able to link science to EMTCT. Karibu, professor.
Thank you very much, Dr. Dwega. And some of these slides might look like Nelly's, but I'm not going to focus on so much on what she has said. I am going to add to what she has said. And I thought my title should be really the last mile to elimination of mother-to-child transmission of HIV. Now, let's go to the next slide. Oh, I'm the one to do this. Now, preventing mother-child transmission of HIV is a longitudinally implemented program. You're following a young woman from hopefully before she is even pregnant, to know her status and to optimize her care. And I think that component of that care is something that we don't fully do. People don't show up because people don't show up in a public hospital because they are kind of thinking they want to get pregnant. We usually show up when, once we're well into the business. In the comprehensive care clinics where women already known and living with HIV are being followed up, I'm not sure we are doing enough in terms of having that discussion about whether somebody's wanting to have a baby, whether it's they're getting optimized care, whether they are even the discussions of their partner involvement. So there's a story, and my impression now is that we are not implementing the strategy of following somebody within the MNCH until their baby is 18 months. And why I say this is that we are seeing young babies born to women living with HIV. The baby is not HIV infected, but the child has tuberculosis. And when you follow the story and ask questions, mom comes to the MNCH, then cuts through CCC to pick up her own medication, and especially now when supplies have not been so great, so they're going there into that space quite a bit of time, and I think that's playing into that story of the babies, and I think there's a need for more research around that. And then of course the other bit is, I go to my ANC, say in Bondo, say Bondo County Hospital. But then my postnatal follow-up for my baby is in Pap Kodek or something, much smaller facility. As a county, as counties or as health, as facilities, you need to see your health facilities as one unit, all right? And be able to plan for that person who's gone out there. That is the other place where people are the issues of how do you organize these services to meet with the person, taking into account the person and their lives. Our experience was that, and I don't think that experience has changed much, is that the mother of a young child, this teenage or young adult we are talking about, is probably newly married, usually just gets 2 hours to go to an ANC clinic. And once she has had her baby, you go to the local facility. Why are you going? Why do you need bus fare to go and to that other facility? You had a normal delivery. Immunization is available here, right? So that needs to be taken into account. Next slide. Oh, I'm the next slide person. Okay. In this slide, I try to summarize the biology of HIV and where we are sometimes falling through, things are falling through the cracks in terms of being able to prevent infection. We must keep remembering that the mother's disease status matters. If you have high viral load, so you're newly infected, or you haven't been taking your drugs regularly, so you're having viral rebound, or you started off business when you had low CD4 count. So in fact, when we used to know, and that story is still true, that when you stop your medication, you go back to where you are in terms of your immune status. So if you are low CD4 count when you're starting your treatment, you will go back there. And your risk for your own health and your risk for your baby is much more if you're immunosuppressed. And these are messages I think we need to convey to our mothers as part of encouraging them to keep coming. Then, of course, failing to take your drugs, maybe you are not diagnosed, maybe there was a stock out, or the suboptimal retention. This is an issue here. This is an issue. Good planning. Do you have enough stock to cover you? Are you communicating well among yourselves, or are you having little domestic going on so you don't talk to somebody, so you can't even ask them, by the way, do you have extra medicine? We are running out. You know, this sort of thing. Good teamwork and support. And then the lack of viral suppression while you're on ARVs. So there's poor adherence, there's suboptimal ARV protocol follow-up, and then resistance. Now, again, what your county, what are they able to deliver on? Are they telling you you're virally suppressed just because your viral load is less than 1,000? Are they able to tell you when your viral load is less than 400 or even lower? I don't put up that slide here, but the women who have CD4 counts that are below 1,000, but their viral load is between that 400 and 1,000, what you call low-grade viremia, we have data showing that HIV transmission rate of about 7%. So the clarity and having a clear message of that, you really, really need to be suppressed. You really need to have undetectable viral load to protect that infant. Let's go to the next slide. Dr. You did very well, but I want to highlight the issue of primary prevention. The majority of women who come to an antenatal clinic are not HIV infected. This is part of the success of our long-term engagement in prevention of mother-child transmission. So my question is, this young woman who is not HIV infected, are we giving her her package of care? And her package of care is identifying whether she has risk. If she has risk, it's providing PrEP. It is inviting her partner for testing, right? And if he's infected, it's providing him with the ARVs. Are we doing that? I don't know. I'm not sure. So that to me is a priority. So you have somebody who's at risk because they are pregnant, so they are in a intimate sexual relationship with another person. We need to prioritize some of the key triggers that somebody might be at risk is the presence of gender-based violence in their relationship. As health workers, we ask that question. Is there the space, you remember there are the secrets. We're asking about the secrets of somebody's relationship. we did some work in Kisumu, and we clearly were able to show when the question to ask is, are you frightened of your partner? This, unakuwa na uoga na bwana yako. That, if the woman answers yes, that's usually a very clear indication of being a victim of gender-based violence. And that is a good marker of somebody who's at risk, who should be prioritized for counseling, skills on conflict resolution, and maybe trying to even get a partner on board. And you try to do a bit of marital counseling. I will not go into this because Nelly did a great job. You did a good job, but just highlight that, sorry, the regions of Kenya with low HIV prevalence are the ones that are having the highest mother-to-child transmission of HIV. Okay? So nobody should sit comfortably at the hakuna shida. We need, and we know that we usually tend not to send so many resources to where we think that they are few. We have a crisis in the education sector right now.